and welcome to this month's edition of the Rural Doctors Programme. I'm Jerry Gannon. Thanks for joining us. The focus of our programme this week is abdominal pain, but before we get into that, here's a word from the CEO of Rural Health West, Belinda Bailey, about an upcoming and important conference.
Hi everyone, this is just to let you know about our Aboriginal Health Conference that's coming up in the next few weeks. It's actually the 2nd and 3rd of July at the Pan Pacific, and everyone at Rural Health West is really excited about the conference. We think it's going to be a really high quality program this year. We've got some amazing speakers, we've got some amazing sessions, so we'd love you to go onto the website and have a look at the program and maybe think about registering while you're there. The conference, as you know, is about building strong communities in Aboriginal communities, and I think that our program really does reflect that theme. But of course, most importantly for us at Rural Health West, I think this Aboriginal Health Conference is about an opportunity for our very dedicated Aboriginal medical service doctors to come to Perth, get together, network and share their sort of stories and experiences about what it's like to work in these communities. So whatever happens with our conference in terms of its program, we are very focused on making sure our AMS doctors get a chance to spend time together. But it's also an opportunity to broaden our participants at the conference. We really are committed to making sure we have a multidisciplinary approach to Aboriginal healthcare. So this year we're looking to have students, nurses, allied health workers, Aboriginal health workers, and everyone who really cares about Aboriginal health. So we hope to see you there.
Thanks, Belinda, and that sounds like a very important and worthwhile conference. Well, to the subject of today's broadcast, which is abdominal pain. And joining Olga Ward is General Surgeon Dr Craig Hendry, together with Gastroenterologist Dr Warwick Ruse. Olga.
Craig and Warwick, welcome to the program.
Thank you.
Thank you.
Abdominal pain is quite a common presentation in a general practice, but some of the time it's quite difficult to diagnose. Are there any signs and symptoms and conditions that perhaps we shouldn't miss, that we should think of either straight away or that should always be in our differential?
Well, the reality is that serious causes of abdominal pain can have no symptoms whatsoever.
Yeah.
And so it gets lost in the noise of the very common. So in a way there has to be, I think, a fair bit of clinical acumen and putting the whole package together as to what the symptoms really are. I mean, I think that, as a surgeon I see a lot of anorectal bleeding, and usually it's pretty obvious that it is going to be a lower anal cause, hemorrhoids, fissures and that sort of thing. But for example, if blood is mixed in with the stool, then that would be, and even if the patient is a bit uncertain as to that, I would be a little bit more aggressive in my management.
What about you, Warwick? Are there any patients who present with pain and you think something about that doesn't quite ring true?
So I feel a bit of a fraud here because I sit with a sort of 3 to 6 weeks filter between me and acute pain, so I very rarely see it. Mm-hmm. But
there's certainly plenty of patients with chronic abdominal pain.
Well, we're going to get to that. But I would think that acute pain, you've still got the basic, but mouth shut, ears open. If they can, let them talk and tell you about it. But and then it's the usual thing anywhere. Just how long have you had this? Because I think Craig will probably agree.
Time's important.
If it's something for 2 or 3 hours and they really look sick and they've got a temperature, there's something going on. Whereas if it's very bad today, doctor, but it's been going on for several weeks, they're probably not going to need a knife laid to them today. They may still very well have something serious. And I'm always a bit worried in myself and in other people about having the list early into which, or the pigeonholes into which I want to push people. I'd much rather be the cold case detective and hear what the facts are, ma'am, and then put together a diagnostic thing. Because I must say, even in my time-filtered practice, got a lot of people coming in who'd obviously said a word or pressed a button and everything had gone rolling, and it really wasn't. Reflux, to me, is the classical one. It's a word where doctors and patients trip each other up. But I think it's the person on the ground, particularly in general practice and particularly in rural practice, that you listen, you feel, and then you probably do know in terms of the broad thing, do I need to call Craig straight away? Do I need to call the laboratory in tonight? Or have we got a bit of time to work it through?
Well, obviously surgical is peritonitis. So, if a patient has peritoneal irritation with rebound percussion tenderness and very localised tenderness, well, that does push you into a more surgical bent. But timing is important, especially children as well. I think that children will often present with quite impressive abdominal pain acutely, which often just disappears over 12 hours. And so I don't get too excited about children before 12 hours. We might observe them, certainly for family reasons, but if it's been lasting longer than that, then there may be something else going on.
I have seen children more recently with appendicitis, but when we were doing paediatrics, a large number of children got this label of mesenteric adenitis. What's sort of going on with those kids?
I have no doubt that there is a real entity, mesenteric adenitis, and you can sometimes, at appendicectomy, see inflamed lymph nodes in the mesentery, down in the right iliac fossa. And I have no doubt that, I mean, non-specific abdominal pain is a dustbin diagnosis, and there is a normal appendicectomy rate, which shouldn't be more than 20%, but it often is.
Kids with appendicitis who have something that really does look like appendicitis with peritoneal irritation, does it ever just go away?
Oh, there's no doubt that appendicitis will usually resolve, not unlike diverticulitis. I have no doubt that with, we say, conservative management, with just fasting or fluids and analgesia, it often will resolve. And that's been, I think, shown quite clearly in some particularly Scandinavian approach to appendicitis, like antibiotics and things.
So it wouldn't be an enormous problem, say, if you've got a very stormy night and you can't get the plane in, to actually admit a child in a country hospital and give them, say, fluids and analgesics and sit on them and see what
that would be appropriate, yes. And if you're in Antarctica, yes. You don't take out an appendix on the kitchen table without a good reason.
But in that scenario, just would you introduce antibiotics early on this Scandinavian experience, and except that you might have antibioticised a few mesenteric adenitis, but at least have done the right thing early?
Well, as a surgeon, I don't usually. I usually would make a decision to be operative or not before I give antibiotics. But I do think that in a situation where evacuation is the issue, I would put them on antibiotics early, yeah. Now, the thing is that if an appendicitis resolves, there is a very high recurrence rate, which probably approaches 100% if you wait long enough, but it's 70% at a year.
So you
they come back.
Probably send them past the surgeon anyway just to have a look? Or do you just wait?
Not necessarily. I mean, I think it's legitimate if an attack settles to wait for the next attack, but you know what it is the next time.
And in closer to civilisation, does ultrasound help you? Was that part of the Scandinavian experience?
I was going to even ask about... No, I agree with you. I was going to ask all the time. I was going to ask about this for the country situation because, of course, we do have ultrasound.
Well, the trouble is it's operator dependent.
Sometimes,
So if you have a department with an interest, I think the diagnostic accuracy, or at least the ability to say they didn't see anything, is of the order 80%. But I must say I've never been in a centre where it's anything like that. And so I do not routinely order an ultrasound unless I think there may be something else gynaecological or something going on.
And are there any really unusual conditions that, say, don't come from the abdomen that might present with abdominal pain? And how do you guys screen for them? Well,
children definitely, yeah. I mean, pneumonia, lobar pneumonia definitely does. I've seen that a few times. Right lobe, lower lobe pneumonia, and diabetes can too. So an early ketoacidotic diabetes can present with very impressive abdominal pain. And
I'd heard that acute glaucoma could present just with abdominal pain.
I've never seen that.
No, I saw that on your list and was terrified at the thought of it. I must say I don't go and check their pressures.
And malaria can too. There's no doubt that abdominal pain as a presentation of malaria is not that uncommon either.
So asking about recent travel might be worthwhile, just in the screening questions. What about cardiac pain?
I speak from experience there, having taken proton pump inhibition for my reflux pain while swimming for some time. And it was interesting, placebo effect. It all stopped for a while and then it came back again. So, you know, the old, you know, when a young man complains of his heart, look to his stomach, but when an old fool complains of his stomach, look to his heart is very, very real.
And now that we do have PPIs available, I thought we'd see quite a lot less patients presenting with reflux, particularly since they can get some reasonably powerful drugs just over the counter at the chemist. But a fair few of them are still complaining about quite severe heartburn.
Yeah.
What's going on?
I think part of it is confusion, that if quick ease, take it, hits me in 5 minutes, and Dr. Olga says this is a super antacid, it'll hit me in 2 minutes. So the first thing is, I found that people are waiting for it and then take their medication, and it sort of goes in 20 minutes, which is what it was like with the antacid. The second thing I think is that when you give proton pump inhibitors to the usual large herds of people and put the results through the statistical mill, they all work in the standard dose, give 24-hour relief to about 80% of people. But the herd is composed of individuals.
Yeah.
So some people just need 2 instead of 1 because they need a higher dose to get their 24-hour relief. Some people, if you ask them, say, oh, yes, I take it in the morning and it's great, you know, breakfast is now comfortable, lunch is now comfortable, but they, with a very little, you know, they give a history of it wearing off later in the day. The other problem, I think, is that, well, I've seen, talking to people, mouth shut, ears open, is that often, for instance, if people have nocturnal reflux and they're given the medication and they take it in the morning, they're a bit disappointed that they might get 2 good nights in a week, but they're still having 4 or 5. So I think it is important, first, to establish that it's reflux. Second, what's the timing of it? And then third, a crash course in the pharmacodynamics of proton pump inhibition. 1 may be enough, but you might need 2 to get a result. And unfortunately, you're not guaranteed to get a 24-hour cover with whatever the right dose for you is.
And you might need to take it with the evening meal instead
That's
of breakfast,
right.
yeah.
Exactly. And the other thing is, well, what about the timing, doctor? Being very sleep sensitive myself, I say to people, look, if you only want to take 1 a day and it is waking you in the night, obviously take it an hour before bedtime, get your good night's sleep your morning, and if 1 day a week it hits you an hour before tea time, you might just top up with a quick ease. But if 4 or 5 days a week it's making life uncomfortable at 4 o'clock in the afternoon, talk to doctor about at least experimenting with a regular second dose. And if that's what you need, then doctor can ring the authorities and get you extra quantities.
Craig, are you seeing a lot of ulcers or reflux problems?
Look, it's important to remember that PPIs are such effective drugs that what you've got left over when it doesn't work is other things going on. And I think that it's important to realise that that PPIs don't stop the reflux from happening. It still does happen. And there are other irritants, including bile, which can play a role. And I think that post-cholecystectomy bile reflux is an entity.
I'd agree with that.
And so sometimes PPIs will, you know, as part of the management, are not enough, and you might need to add something else. And you've got a few options. You can use prokinetic agents, which sometimes do, I think, work in addition to
So
PPI.
that would be things like metoclopramide or more.
And
Is
Motilium.
Propulsid still on there?
Prepulsed, I think, was probably the best, but unfortunately withdrawn from the market.
The odd 90-year-old American had a heart problem with it.
But Motilium works. That's what I would tend to use, droperidol.
I think the other problem is coming back to this, taking the history. I've got reflux, doctor, I will take this. But when you ask people about it, it's not the classic column of fire rising and falling. It's a very real discomfort here. And the other one for me is I've tried them all. We tried Somac, and they all worked 10 or 20% for a couple of weeks and then they wore off. And in a lot of those, I think we are dealing with very real esophageal dysmotility, plus a bit of placebo because someone finally listened to me. But most people, in my experience, and as Craig said, I don't see the people for whom proton pump inhibition is a real miracle. But most people say, look, it worked fine. I mean, I got a 90% reduction, but then it wears off in the middle of the night. But the ones to think about, is it good old common or garden reflux is the ones in which nothing really worked for a long time, and it was all right, but you know, a 20%, because I think there we're dealing with esophageal dysmotility. And I'm just trying to save Craig and his colleagues work, because some of these people get swept along, oh well, if it's not working you've got to consider a fundoplication, and I'm sure you've got enough work without taking on esophageal dysmotility.
Well, when you've got that far, you do need to do manometry and pH studies to really work out what's going on anyway.
Are they available in regional hospitals, Craig? So that's all Perth-based investigation?
Absolutely.
Tertiary hospital, or do the private hospitals do it?
There are some of the larger private hospitals will do it, yes.
By the time people have got to that stage and they're seriously considering, you know, I can't go on like this, is there an operation which might help? Then you've got the time to ring up. The other point Craig mentioned, and it's very true, is the basic mechanism of you know, too much pressure up, not enough squeeze holding it all in is very real. And that's the other thing which you often have to ask about, particularly at night. Has the acid gone away? Yes, so why are you here? Because I wake up drowning in my own juices. And there is a small group of people who I ended up seriously considering fundoplication for the pure regurgitation side. It was no longer a vehicle for acid, but it was still a major problem.
And that's what fundoplication does very well. It can be a disaster with dysmotility problems, and that's why you need a good workup before you embark upon that. Yeah.
And most of the surgeons I've dealt with who are very sensible people, it's obvious to me and blind Freddie that there's a regurgitation problem when you wake up in the middle of the night, you know, with a wet pillow and cough. But they still quite sensibly demand the roadmap of manometry and pH monitoring, just in case if there's a pain element as well, and that's really what I want to get rid of, Doctor, if it's esophageal dysmotility.
So with the dysmotility, then you are looking at the motilium type drugs to fix it?
I think you're looking at the tough shit, you know, but that's the way it is. Don't go looking for a knife, and we'll try everything once, but you know, some people get cramps in the legs, some people get period pain, some people get esophageal dysmotility. And
then you look at all the other things like posture and weight loss and putting the head of the bed up and all
so
the things that help just a little bit.
That's right. I think the reason that this quite large group of people whom everything worked but not a lot is because there is a degree of regurgitation which triggers some of the dysmotility, but it's still there ticking away on its own.
Absolutely.
And just before we go to break, Warwick, can you tell me a little bit about Barrett's esophagus and the management of Barrett's esophagus in 2 minutes or less?
Well, 2 minutes or less. Barrett's esophagus is very real to the endoscopist. You're going down this beautiful pearly pink tunnel, and all of a sudden there are these great jagged tongues of orange flame coming up towards you. This is long segment Barrett's esophagus. It's pretty well recognised that it's due to reflux, and the intelligent designer throws the dice every year for a conversion to high-grade dysplasia, and then some of those can go to cancer. The problem is that we now have short segment Barrett's esophagus and the changes of Barrett's esophagus in an apparently normal gastroesophageal junction. So some people say that 25% of the population has Barrett's esophagus, of whom a small proportion will get a very nasty cancer. And that small proportion, a lot of them, it will happen when they are old and feeble, and something else is just as likely to knock them off. So in any individual, you know, if you've got long segment and you're young and you have a history of reflux, you do need to know about it, and you do need to be, I think, on regular screening. But like all these, we'll do a test and we'll put you on regular screening. We, the profession, have some sort of obligation to think, you know, how likely is it that this is going to help? Unfortunately, the days of God doctors saying, well, I won't tell Olga about this because I don't think it's all right, are long gone. Everyone's terrified of the lawyers. I was at a meeting of alleged opinion makers in gastroenterology some years ago, and we were suitably lubricated by the people that set the meeting up. And we got to the stage of me saying, because I like being irritating to these 10 doctors, if you had Barrett's esophagus, would you undergo surveillance? And 9 out of 10 said no. What do you recommend to your patients? 9 out of 10 said surveillance. Because the lawyers are knocking on the door and you know what you do for yourself. And it's one of these things where we can all sort of say, oh, well, it's something the patients need to share. But you tell the patients you've got a pre-cancer and they say, what should I do, doctor? Yeah, so I think the short answer is it's very difficult.
Yeah.
It's when you find dysplasia that you're a bit more, I think responsibility perhaps to be aggressive. At least consider fund application and other options. But
sound of disagreement with doctors here. Yeah. No evidence of fund application or scrupulous proton pump. I tell them, look, it's like having a bomb and a fuse and a match. The smouldering fuse is the Barrett's. The match was the acid. But once it's smouldering, you blow out the match, the big bang could still happen. And what we're interested in is chopping the fuse. And up until recently, it was if you had dysplasia, and this is a problem, your friendly pathologist who's very good with polyps and appendices, he really needs to ring his mate who looks at dysplasia all the time because it is a major decision. It used to be, have your esophagus out. Yes.
High-grade dysplasia.
High-grade dysplasia. In centres of excellence in America where people are very aggressive, they say, doctor, I'm not having an esophagus out, but I want to keep coming to the Mayo and I want to keep being screened. And 5 years later, the high-grade dysplasia had gone away or stayed there. So it's very difficult to say in any individual case, this is what's going to happen to you.
If you eradicated their helicobacters, would that make a difference?
I still subscribe to the fuse theory, but it's all a bit late.
Yeah, I'm not totally convinced. I think if I had dysplasia, I would seriously be considering stopping the reflux with an operation. And I acknowledge that the research is far from conclusive. It just makes sense.
I agree, but because otherwise if you leave it, you're actually blowing on the fuse. But I think the fuse is smouldering away there.
And thanks to Olga, Warwick and Craig for that interesting discussion. Now, we also caught up with gynaecologist Dr Yee Leung about the identification, diagnosis and management of ovarian cancer.
So Yee and Martin, welcome to the program.
Thank you.
Could you talk a little bit about the various presentations that patients come in with when they do actually have ovarian cancer?
The main problem with ovarian cancer, as you know, is that most of the symptoms are non-specific. So the thing that we try to impress on patients is that if they have persistent symptoms and persistent abdominal symptoms such as bloating or discomfort, any alteration in bowel habit or bladder function, that's persistent, and we really do stress that word persistent, that's when they should seek medical attention. But it's so hard to detect.
How long would you classify persistent as persistent?
Yes.
Patients will think it's persistent after 2 weeks, but are you talking sort of several months or several years?
2 weeks is actually not a bad time frame. Certainly if they had some bad Chinese food the night before and they've got some diarrhea and some abdominal bloating, that's not the time to go and see your doctor about ovarian cancer. But if they do have something which is more than a couple of weeks, I think it is worthwhile to pursue that.
And Martin, when the patients come to see you, obviously they've already got a very clear diagnosis. Do you see any additional symptoms or presentations that you think, gosh, that was a bit unusual?
Well, I think it's always easier for me because patients kind of look back in retrospect and say, well, I developed these problems and then it led to the diagnosis being made. But as Yee says, ovarian cancer is renowned for being a very vague presentation, often non-specific symptoms over quite a long period of time. And there's no one single symptom you could say, well, this highlights the risk of ovarian cancer. So I think people just have to be alert for things that don't clear up with simple measures and see their own doctor.
Often you'll get a patient, particularly in the country where you don't have access to very sophisticated imaging, you'll get a patient with a kind of an upper forniceal mass or an abdominal mass and some vague symptoms, and it'll come back from the ultrasound saying there's a complex mass. And then you're not quite sure whether it's a dermoid or endometriosis or ovarian cancer. Are there any particular pointers that you might
Yes, we do
through?
use a risk of malignancy scoring. So patients who are referred to King Edward with a mass, whatever that mass is, we will triage to whether they see the oncology service or general gynaecology service. So the factors we look at are age, whether a person is premenopausal or postmenopausal. So if the woman is postmenopausal, they're at higher risk of ovarian cancer. That's the first thing. Secondly, we look at the ultrasound features. So if it is complex, they score higher than a simple cyst. A simple cyst is very unlikely to be an ovarian cancer. Yes, you're quite right, dermoids will look complex, but a good ultrasound will tell you whether it is dermoid or not because of the characteristics within the, or the sonar features that are present. The cyst that's most confusing is the endometriotic cyst. And the reason why it's confusing is that the third factor we look at for scoring the risk of malignancy is a CA125 tumour marker. Yeah. And in endometriosis it's often elevated. So we calculate a risk of malignancy score on the basis of age, ultrasound characteristics and CA125 level. And if it's greater than a certain level, then we would see those patients because they're at high risk. Even that screening is not 100% reliable. It is probably about 70 to 80% reliable.
What do you do as an oncologist, and certainly what should we do as a GP to reassure patients with a load of vague symptoms but a very high anxiety level?
I pity you guys in GP land. That's the first thing, because it is very hard. There will be patients out there who are very anxious about symptoms which you know are going to be related to their bowel habit or bowel problems. If they are concerned and they are symptomatic, it does warrant investigation, and the investigations you've mentioned already are an imaging of the abdomen and pelvis as well as the CA125. You can use that as your initial screen or triage to help you ascertain whether they have a significant problem or not.
And could both of you talk about CA125, very beloved of patients who read the internet and the Women's Weekly and the West Australian, but they think it's a screening test. And sometimes it's quite hard to explain to them that it's not a screening test. So could you give us a few pointers?
Certainly CA125 is very helpful in managing ovarian cancer. We use it a lot to help determine if a patient's responding to treatment, if they're in remission, or if maybe they're out of remission and they're having a recurrence. As a screening test, it's not very effective because there are a lot of false positives and that when it's been used in screening populations, it's only been found to detect early stage ovarian cancer at a low level. So the benefit of doing the test in the detection of early stage curable ovarian cancer has not yet been really strongly proven. If a patient has vague symptoms and a slightly elevated CA125 level, then I think that certainly does ring a few bells and makes you kind of approach the problem a bit more seriously in terms of, is this an ovarian cancer or not? But to do screening across population levels because their sister's cousin had ovarian cancer and they're concerned that they might be at risk, I don't think is necessarily a wise way of using a blood test. As I said, it's not 100% reliable and it does require some interpretation.
Yes, a whole range of issues can cause the CA125 to be elevated, and they range from gynecologic problems, including menstruation, fibroids, endometriosis we've mentioned, pregnancy obviously, through to non-gynecologic problems such as liver disease, renal disease, anything that actually causes a bit of peritoneal irritation. So diverticular disease, appendicitis will cause elevations.
Oh dear, all the things that also cause vague abdominal symptoms and bloating.
Pelvic inflammatory disease.
Pelvic inflammatory disease,
so, there's lots of...
lots of things to screen for before you get your knickers in a knot. The West Australian recently published an article about the newest, latest, greatest, perhaps in the market soon, ovarian cancer screening test. Does either of you know much about that, and could you comment on what's coming?
That's probably the HE4 that they're referring to, which is actually human epididymal factor.
Yeah.
Okay, number 4. It's been shown to be elevated in ovarian cancer. Supposedly, the advantage of HE4 over CA125 is that in early ovarian cancer, in 50% of cases, the CA125 is not elevated. That's the main failure of the CA125 as screening, as we've mentioned. But in HE4, it's meant to be more sensitive at picking up early ovarian cancer. We don't think we should actually be introducing that into Australia at this point in time unless it's actually in the context of a trial, because it's very easy to introduce these tests, which then becomes another CA125. People will start asking for it, and you're going, okay, well, it's up. Does this mean that it's really there, or is it not there? So it's probably one that we would try to keep on the back burner rather than making it one of the tests to replace the CA125.
And how much advantage is actually conferred by an early diagnosis?
Well, it's major advantage. The survival rates, 5-year survival in early ovarian cancer, is over 90%. 5-year survival in most of the stage 3 ovarian cancer we see is about 30 to 40%.
Is that your experience as well, Matt?
I think that's right, yes, that the more advanced the disease, the less effective the surgery in removing all of the problem, and the less likely that chemotherapy will obtain a complete remission. So if we can diagnose ovarian cancer at an earlier stage, then the advantage is there for the patient. Unfortunately, that's not always the case in the current tools we have.
Yeah. Now, always when we were being trained, ovarian cancer had an absolutely abysmal prognosis. Has it improved a lot over the last, say, 10 or 15 years?
I think we're seeing small steps, as what normally happens in oncology. We don't seem to make massive gains that patients often expect we should, but we're making incremental progress. The advent of intraperitoneal chemotherapy has helped lift the cure rate of stage 3 ovarian carcinoma a little bit. We're now looking at newer agents to try and maintain complete remission in people who have finished their surgery and chemotherapy. So there are some exciting new clinical trials coming to West Australia in the next 12 months. So I think that we're making steady progress, and our improvement in the drugs that we use and the approaches that we take have meant that the prognosis of stage 3 and 4 ovarian cancer has lifted quite considerably. And many people, such as myself, often think it's now more of a chronic disease, that ovarian cancer can turn into a chronic problem where we're treating patients for a period of time and then stopping treatment and observing, restarting treatment. So much more common for patients to survive longer and hopefully have a better quality of life.
And our thanks to gynaecologist Dr Yee Leung for his time. And now back to that discussion with Warwick and Craig and Olga.
A lot of our patients turn up and they say, oh, it's just me diverticulitis plain, oh, doc. And they've usually got a mild fever and a vaguely tender belly and not a great deal else going on. How should we manage them?
I would, obviously you listen to the patient and symptoms, but it is a very common scenario, and I would scope them. You know, it's a colonoscopy up front. Colonoscopy will usually exclude serious other pathology, and you'll usually get
more
a
common
reasonable,
in that age group anyway. Yeah.
And you'll usually see diverticulae, although I must say I think the diverticulae that probably cause the most trouble are probably the small ones with small orifices, and they may not be that apparent at colonoscopy. And the good old barium enema is still the sort of the gold standard when it comes to documenting diverticular disease, but I certainly wouldn't do that without good reason. So,
do they turn up in your office, Warwick?
They do, often with a request for colonoscopy, which I don't have to disagree with Craig. Diverticular disease is incredibly common, and it's the continuation of good old irritable bowel. If they've got, going back to your scenario, I think if they've got a fever and even vague abdominal tenderness, yes, I would accept that as an acute diverticulitis, particularly on Friday evening, and put them on some antibiotics. The situation I tended to see more was attacks of left iliac fossa pain, treated quite frequently with antibiotics, and what are we going to do about it? Particularly if the attacks were so frequent that the patient was thinking, couldn't Craig take his knife to me and get rid of all this? To which I would say, well, pain hurts, we accept that, but irritable bowel leading on to diverticular is a spasm in the guts. We really need to know if all of these attacks are proper itis. And certainly in the metropolitan area, it was easier for doctor at least once in one of these attacks to whip off a white count and to get a CT scan or an ultrasound to see if there was some clever peridiverticular changes that our friendly radiologist could see. And if you could nail one of whatever your attacks are, as obviously, as far as obvious is in medicine, having a true infective element, then we could look at the previous or over the next 12 months frequency of the attacks and say, look, we can get you over them each time with the antibiotics, but it's going to be like this for the foreseeable future. Why don't you go and talk to Craig about a surgical option? On the other hand, if there wasn't anything obviously infective, then you could say, well, perhaps we are dealing with very severe spasms. You don't need to take up Craig's valuable time. And what are you doing about antispasmodics and things like that? But it's something that I imagine was happening a lot in general practitioner surgeries, and they were filtering them out and I never got to see them. But I still got quite a few people that we had to have that talk about.
Yeah, I think quite a lot of patients will have a screening colonoscopy for another reason, or for, you know, for very vague symptoms, and they'll come back with the diagnosis of having, you know, diverticularly present, and then it's a bit easier to make the diagnosis. When do your alarm bells go off?
Once again, the retrospectoscope. What are we here to discuss? Oh, you know, my attack of pain, you know, 2 weeks. But how long have you been getting this sort of pain? And I sat in Bentley like a hunchback spider in a web for 30 years, and I had people coming back quite a lot. It was fascinating. I would sit there and say, oh, here you are again. Well, you know, I might remember your bum, but I don't remember your face. I better just check your notes. And we'd go through it all. And they'd said, oh, well, that's what I'm here about again. They had genuinely forgotten that they had... Now, obviously, if it had been 5 years that they'd forgotten, you have to rethink this lot of symptoms. But sometimes when we were sort of shaken up, saying, well, you know, you have had a colonoscopy only 4 years ago and I am good at it, but, you know, sooner or later I'm going to pop someone. They could see the bigger picture. Whereas if they just get swept away with a word and a slot on next week's list, I think that's where accidents can happen.
Speaking of things that intermittently flare up and things that you have already mentioned, irritable bowel disease or irritable bowel syndrome.
I'd prefer to think of it as irritable digestive system. No, seriously. It has a lot of... I mean, let's face it, the gut is an incredibly stupid organ.
Yeah.
All it can do is hurt or not hurt, bloat or not hurt, feel sick and vomit, shit too much and shit too little. I mean, you know, it's not a huge range of things can happen. But irritable bowel, if you go out and just knock on people's doors and say, here's a scratchy matchy, can I have 10 minutes of your time? What bank do you use? By the way, do you have any of these symptoms? Probably about 30% of the population will describe very minor blips of irritable bowel. I am told that 5% of videoed and analysed GP consultations are probably about irritable digestive system. And certainly in specialist practice, at least 30 and probably 50% of people end up with the diagnosis of irritable digestive system. It is incredibly common.
Yeah.
And
yet, you know, the patients will come in sometimes with very acute pain, often looking like they might
there's either collagenous colitis, which is in the subepithelial part there's a layer of collagen, or a lymphocytic colitis where there is extra lymphocytes. So that's the last one, is certainly yet another inflammatory colitis. It's usually, well, in my experience, probably in Craig's, we do this because some enthusiast biopsied everybody every time and realised that some of the quite significant diarrhoea problems with an apparently normal colon, hey, there's at least something wrong. They don't yet appear to have the dysplasia and going on to cancer risk, but roughly speaking, you can still start with either your cilazapyrin type medication or local steroids with a modest, not as good as with the proper colitis, chance that you will improve the symptoms. But once again, if they are a worry wart who's having 2 poos a day instead of 1 and they're found to have lymphocytic colitis, you can't hush it up, but you just say, well, really, we can't cure it. The best we can do is treat it. Now, do you really want to go on steroids to have 1 poo a day instead of 2? And most people can be talked around, but it is useful to know about it for the person who does have the 5 or 6 quite catastrophic poos a day, that if they wanted to, you could walk up the ladder of treatment.
Yep.
Do you see them at all, Craig?
I've started seeing a few, yeah. I must say I haven't made it a huge practice to biopsy, obviously, normal colon, but I'm doing it a bit more now, especially with the people whose primary complaint is diarrhoea.
So I think that's, it is one of the reasons why it is important that the colonoscopist knows why he's there. Because if it is a major diarrhoea problem of relatively recent onset, it's good that it's not a roaring, great pus-filled hellhole of Crohn's, but there could still be something other than good old irritable bowel which you could treat.
All right. So, and really it is just kind of mild background inflammation?
No, to the naked eye, it looks like perfect, but it's only our friend the pathologist who puts the ripples in by reporting what is a genuine condition or two genuine conditions.
The biopsy shows then some inflammation or some inflammatory cells. How is that causing the diarrhoea? Is that just simply causing a motility type diarrhea, or is it a secretory thing? Do you know?
But if we want to fly, the collagenous colitis is probably something to do with this great layer of scar tissue under the epithelium. Is probably something to do with the normal transits, and lymphocytes will stir you up wherever they are. But I think the honest answer is nobody knows. It's good old fashioned rustling in the bush and shooting medicine. We recognise it. It's a small tiger, not a rabbit. And if you want to put something in your gun, you can use cilazapyrin. And if you really want to think about steroids, there is something that's, it is worth considering. But probably if you're getting onto steroids, and as a GP, I would shift the burden onto a gastroenterological set of shoulders.
Craig and Warwick, thanks very much for joining us tonight. Yeah. And do you have any final sage words of advice about bellyaches?
I didn't get a chance to say that. I think that the pendulum has gone well back on surgical management of diverticular disease. We're very much more conservative than before. It's actually, apart from the very acute perforated disease, very reluctant to electively operate on diverticular disease.
So we'll keep that in mind.
Yeah. And I guess, my 2 words for advice, don't pretend they're wisdom, is one, however busy you are, take a history. Often things will fall into place, particularly right now I'm feeling very sick, doctor, but if you gently take the time and you realise that it's episode 43, it does change things. And the second is to be very careful with labelling people on the basis of a quick symptom. You've got reflux, it could be dysmotility, you've got diverticulitis, it could be diverticular disease and lots of spasms. And the rest is medicine as we know it.
Well, finally tonight we caught up with the radiologist to have a look at some of the tools and equipment that are used in the diagnosis and management of abdominal problems.
Sven, intussusception's not an enormously common problem, but it's certainly something we all learnt about in paediatrics. Could you just remind us what's happening when somebody has an intussusception?
What happens is that the bowel telescopes into itself. It's like pulling a sock inside out, so to speak.
So what makes it turn inside out?
The most common cause, we don't know.
Mm-hmm.
But sometimes there's a so-called lead point, and that can be something like a polyp.
Yep.
It could be an enlarged Peyer's patch. The most common age group in children is between about 2 months and 2 years of age.
Yeah.
And in most of those cases, we don't know the actual cause.
So if a GP in the country sees a patient and they suspect intussusception, what will the kitty look like?
Well, it usually has screaming episodes, drawing up the legs, going pale. And if it's been going on for a reasonable amount of time, they can even have blood in the stools.
Yep. So that's the classic, what they call red currant jelly.
Red currant jelly. Why
stool.
they always refer to food, I don't know. But anyway, yeah.
In a country emergency department, we might suspect an intussusception or some other kind of bowel obstruction in a small kid. What sort of radiology is worthwhile, given that radiology departments in country departments are quite limited?
A plain film, I think, would be useful because it does demonstrate where there is a paucity of gas. So here's an image that shows that there's a lack of air on this side, which means that the intussusception is actually occupying the ascending colon, and it's going up the right flexure and into the transverse colon. You can see the mass here displacing the gas. We call that a windsock sign. But I think more importantly is to see if there's an obstruction. In other words, you get dilated small bowel loops, or even worse, free gas in the abdomen from perforation.
Yeah.
And then if there is an ultrasound machine available,
Yep.
it is not so easy to miss an intussusception really, because they displace the gas, and they're quite easy to see. This is a typical example of an intussusception ultrasound, which shows a so-called target sign with the layers of small bowel going into large bowel. So that in the center we call that the intussusception, and the outside layer is large bowel, and we call that the intussuscipiens. And we don't just take a picture to diagnose the intussusception, we also use this to have a look at the vascular flow with intussusception. So we do a so-called Doppler, where we look at the color and see that it actually is vascular, because if it's not vascular, it can be necrotic bowel, and we don't want to do too much.
Okay, so this one would be suitable for reduction because there's some blood flow here.
That's right. Yeah. If we get something like this, where we don't get much blood flow, then we are very careful about reducing it, because if it's necrotic, you can actually, once you reduce it to some extent, you can relieve the venous congestion in this, and let the cytokines and endotoxins escape, which can put the patient in shock and become severely ill.
So when we've sent the kitty down in your general direction with a provisional diagnosis and they come into Princess Margaret, what happens to them here?
Well, they're triaged in the emergency department as an emergency case. We are contacted either if it's a normal working day in the radiology department, or if we're on call at home, and we will do an ultrasound as quickly as possible.
Yep.
And if we have confirmed the intussusception on ultrasound, then we will contact the surgeons, or the ED department will contact the surgeons once we have confirmed it. And after that, we arrange a gas enema, as we call it.
Yep.
Yes.
And that's curative in all cases, most cases?
Well, in most cases, certainly. About 85% we can get back by pushing it back with air, with an air enema.
And the rest of the children then have to go off to operating theatre?
Yes, then the rest have to go to operating theatre. Sometimes it's a good thing to actually repeat the air enema after an hour or two. Because it does reduce once partially reduced, it does reduce the sort of venous congestion and so forth, but and it can be successful the second time around.
This is a radiology department. I imagine that a distressed child with abdominal pain would be quite difficult to manage in here. Do you also give them an anaesthetic or some sedation or some ketamine or something?
No, we certainly don't give an anaesthetic. So sometimes they're sedated, sometimes the surgeon might not want to sedate, in which case it's quite useful, because the patient can help push the intussusception back. just with the pressure on his abdomen. We do have to strap them down, unfortunately, so they don't move around, because we have to screen constantly in case we perforate.
And Sven, here we are in your chamber of horrors as described, where children hopefully get their intussusceptus reduced quickly. The equipment doesn't look all that sophisticated. Could you talk us through it?
No, there's some very expensive equipment we can use, but there's some very cheap equipment, like a converted sphygmomanometer.
Yep.
That was going to be thrown out. It cost us about $2.50 to convert to a reduction apparatus for intussusceptions.
Yep.
And basically it's just the pressure manometer,
Yep.
which measures in millimeters of mercury. And we have a tube which goes to a catheter. And this is the catheter that we insert into the...
So it looks just like a standard Folger's catheter.
Into standard Folger's catheter, into the rectum of the patient, and the size of the catheter obviously varies with the size of the patient. And we strap the buttocks very, very tightly to avoid the air escaping. And then we basically just pump the pressure in.
Okay, so you can hand pump this.
We hand pump it to make sure that we have the correct pressure, and we don't go above 120 millimeters of mercury in between Valsalva. And we keep that pressure up for usually about 3 minutes if we can, and then give it a rest, and if we can repeat it 2-3 times.
How long would it take to reduce an intussusception?
Most cases they go the first time round.
So only a couple of minutes and it's all done?
Yeah, and it's all done.
And you've got them under X-ray control, ultrasound control?
No, it's X-ray control. It's a constant X-ray control. We have to see if they perforate straight away and stop the pressure. So here's gas being pumped into the rectum, and you can see the intussusception sitting very low down here in the sigmoid region. In the next picture, you'll see it's been reduced to the mid-transverse colon.
And is the aim to get air all the way around to the small bowel?
The aim is to get it right down to the ileocecal valve and out into the small bowel, yes. So in the next picture, it's situated somewhere here. It's quite hidden, but you'll see that there's still a small part of the intussusception in this particular case which hasn't been able to be reduced.
So it's actually a huge length of bowel that turns inside out. It's not just a small piece.
In this particular case, it was a huge amount. It's actually gone a long distance, yes. I think I have another study here. Here's one that's sitting by the ileocecal valve, and you'll see better the difference between that picture and the next one, which shows all the small bowel filled with gas, so this is reduced.
Sven, that was very enlightening. We hope that not too many of our patients will come your way, but most reassuring. And thanks for joining us today.
Oh, pleasure.
And that's our programme for tonight. Now, don't forget, if you'd like to review this or any of our programmes going back to 2008, you can do so by simply visiting us on the web at www.ruralhealthwest.com.au. We're back on July 5 when we take a look at issues surrounding chest pain. From Dr. Olga Ward and myself, Jerry Gannon, and all the crew at Rural Health West, good night and thanks for joining us.